pelvic surgeon. In the last 8 years, I have performed more than 1,000 pelvic surgeries. And in the last years, I have performed more than 20 surgeries with the technique that I am about to explain. I have no sponsors of any conflict of interest when I'm sharing this information. This is the order of the topics that I am going to present to you. In the treatment of the pelvic fractures, we must recognize the contribution of Judet and Letournel in pelvic reconstruction. The classification of the pelvic fractures by type and the description of the injury mechanism of Young and Burgess, and the contribution of Mata in the forecasting of result, and of Root in the percutaneous screw technique. Taking advantage of contributions previously described and the experience acquired in my practice, I started to use a percutaneous fixation technique, but using a nail. This technique describes the fixation of the iliopubic branches percutaneously. It can be used in very high or intermediate iliopubic branch fractures, no displaced or slightly displaced fractures, and the fractures associated with the posterior frame fractures or contralateral fracture. This technique also have contraindications, like fracture associated with the hemodynamic instability due to bleeding, bladder injury, neurovascular injury, and like other ones like deep coxa and very narrow iliopubic bone. To perform this surgery, we need a fibula nail, a Foley catheter, a fluoroscopic control, and surgical table radiolucent. Now I'm gonna show you a video for a surgical technique of the anterior pelvic nail. In supine position, a percutaneous needle approach is performed, measuring approximately 1.5 centimeters. We dissected with blunt scissor until reaching the body of the pubis. Anterior and medial table of the pubic body is drilled with 6.1 millimeter cortical punch unit. We check this step with 2 projections, oblique outlet and inlet. In order to make a space through the medullary canal of the iliopubic branch and supraacetabular, we use a reamer, 3.1 millimeters. Before inserting the rod, it is molded with 2 bending irons. So that is the shape is more anatomical. This step is modified according to the fluoroscopic visualization of the iliopubic branch. This requiring the type of pelvis and acetabulum of the patient with pre-surgical images. The endomedullary road is introduced through the medullary canal of the pelvic branch, with using the inlet and oblique outline fluoroscopic images to have two more orientations. It is possible to block in the road with the locking system can be applied in the thin patients. It's not easy in the obese. Another options to do is with freehand blocking with two projections, oblique inlet and outlet, locking the anterior-posterior orientation of the holes. The locking hole is drilled with 2.8 millimeters drill and 3.5 millimeter screw is placed. In those patients whom the insertion of the rod has been very low, there is a risk with the inguinal canal is located right in the side of the locking system. Has the solution draw back a mini approach to be implement to move the inguinal canal structure aside with the blunt forces. Having seen the technique, I want to show you some of the specific cases, starting with the first time we decide to apply it. The first time we considered the possibility we have received a patient with a pelvic fracture, a right supracondylar amputation, and a left distal femoral fracture. And we asked ourselves, could we do something different in pelvic fracture for an early recovery? And we were successful. Then we consider, could there be a benefit using the technique in the patient with the pelvic fracture and osteoporosis? You can see the fracture in the right branch, and we fix it with the pelvic nail. And then we ask ourselves, in what kind of pelvic fracture we could use the nail. And since then, we have used it in more than 20 cases, including bilateral fractures, high and low fractures, and anterior columns. We applied the WOMAC scale to know the perception of the patient about the results of the surgery. We have operated on more than 20 patients, but we obtained the responses from 13 patients between the ages of 19 to 67. Now we can see the variables of the WOMAC scale: pain, stiffness, and functional difficulty that are higher on the average of the male. And the group between 35 to 49 years old present a greater functional difficulty. The group with the more than 10 days for surgery has the highest average in the three variables. Now, as you can see, the functional difficulty has a greater variability and reaches higher scores than the pain or stiffness. Stiffness is the variable with the most satisfactory result. However, the median of the three variables is below 30. We analyzed the radiograph at 2, 3, 6 months. 100% of the patient presented fracture consolidation. All the patient had a satisfactory evolution of the surgical wounds without any report of post-surgical infection or bleeding. 94% of the patient were consolidated 10 weeks after the operation. Traditionally, the treatment of the fractures from pelvic and acetabular injuries involves complex approaches with the significant complications. We want to share this with you because this technique has benefits: less bleeding, less surgical time, less surgical risk, and a quick recovery. More time and more surgical cases are required to establish the possible complication of implant use and surgical technique. None occur in this group of patients. Thank you for your time. These are scenarios of Costa Rica. And as we say here, pura vida,